is that I know what to do about the drugs that I prescribe and which I'm familiar with, but I'm often unfamiliar with a lot of other drugs that are being prescribed by other doctors who are treating the same patient. So any recommendations on who should take responsibility? I'll give an example. For example, let's say it's someone with a stroke, and let's say I'm the primary physician. Should I then take responsibility? Is that your view? Or, that's question number one. And the other is that, is there any software solution that's available which will help us choose and decide what we ought to do when we are in front of the patient, because we don't have the information in our heads?
Well, Krish, those are two excellent questions. Who are these mythical physicians who can oversee everybody? I think general practitioners, as we have them in the UK, I think it's very challenging. They have an awful lot to do. I mean, without wanting to appear to be ingratiating myself with the audience, clearly elderly care physicians, I think, are amongst the last general physicians. But I would see that we now have to reverse, and I think we're starting to do this in the UK, we have to reverse the trend which has seen all our general physicians melt away, and really elderly care medicine, and dare I suggest it, clinical pharmacology, although frustratingly for me we're a much smaller specialty than elderly care physicians. But I think these are the few specialties now which actually can look more broadly in a more holistic way, and I think that approach needs to come back. Of course, I'd like them all to be called clinical pharmacologists, but whether you call them general physicians or elderly care physicians, that's okay by me. But this is the approach which I think needs to come back, because we are dealing with a morbidity, polypharmacy situation for most of the patients who come to hospital, and many who are being seen in general practice, and there are major training issues there. In the interest of time, I won't go on about that. Just to say very briefly, I think what's happening in terms of the electronic input to medicine and decision support is absolutely fantastic. I mean, we're just on the cusp of a massive improvement in that technology. I mean, I won't ask you to pull out your mobile phone, but I bet it's one of those really nice ones with Samsung or something like that. I mean, on those kind of phones these days, you can bring the world of medicine basically to the bedside. Of course, some of the software isn't as good as it might be, and some of the information which is actually providing the decisions could improve significantly, but that is the world that we will be moving to. And while that won't allow you to speak to the patient, and so much of this is communicating with patients, because many drugs that we might think patients should be taking, they actually don't want. But of course, this kind of thing can help with the counselling, because you can actually show patients what a number's needed to treat of 6 or a number's needed to treat of 100, what it actually means for them in a visual way. So we could talk about this subject for a lot longer, but that's hopefully a brief answer to those two important points.
Can I? Yeah. You mainly your lecture mainly focused on England and Britain, and Scotland, where there is a common pathway where it is mainly NHS, and there is a regulated method of looking at the prescriptions and also the practice of the doctors, whether it is a general physician or a specialist, because most of them go through the NHS pathway. And there is, I know that the pharmacist is a part and parcel of the multidisciplinary team. Often we have to actually rational why we are prescribing a particular medicine for a particular patient. How do you see that vis-a-vis in a country like USA, where it is much more HMO rather than a common pathway of being governed and implemented by the government? How do you see polypharmacy? Because that would sort of tell a lot of stories about, apart from that study, in India, where there is a 50 to 51% private-public partnership, in the healthcare. It's a very, very different scenario here, with less regulation, regulated in the implementation of the medications used by the physicians.
Thank you very much for that point, which again is a very important one. I do have the luxury of going from a healthcare system which accounts for around about 96% of the healthcare delivered in the UK. Without prolonging the discussion, that makes it easier. Real challenges if you have a disjointed healthcare system, and I don't know how early in the day we want politics to come into it, but I mean, I think that is why I think joined up healthcare systems, for all their inefficiencies and maybe some of the things that they can't do, I think in an era where medicine has become extremely complex, I think they're going to do best. I just think if you break up a healthcare system, then you have immediate problems of communication, working out why decisions were taken by one group rather than another, and you don't have that pathway where you've got a general practitioner, associated services such as pharmacy. So probably I should do no more than say it's a much more challenging issue, because of course the other problem is the incentivization is completely different to actually prescribing medicine. So all I can do is count my lucky stars, or we're back to stars and galaxies again, sorry about that, but I can count my lucky stars that actually I work in a system which is, despite knocks from one side or another, still relatively joined up.
The concept of polypill, which England is credited with, it originated that. It definitely improves the compliance, especially in the elderly, forgetful, demented old people. Usually it combines an antihypertensive, a dyslipidemic drug, plus aspirin. The flip side of that is you're not able to individualize the components of the medications. So what are your thoughts on this polypill versus individualizing the drug prescriptions?
Well, for anybody who thought my talk was a little bit too long and they were getting a little bit sleepy, the slide on the polypill disappeared with about 50 others last night. So I didn't have my slide on the polypill. Briefly about the polypill, as a clinical pharmacologist, we were all against these sort of combination products, because this wasn't pure pharmacology. You're not going to be able to tell which is the product which is actually causing the adverse reactions. But my feelings over 20 years have changed significantly. We clearly are in the era where patients are taking lots of medicines. I've shown you data to suggest that the number of medication-taking episodes is important in terms of compliance, and I think whether it's the polypill as originally constructed or a different kind of polypill, I think that approach will definitely come through. It'll create its own problems when something goes wrong. How do you work out which part of the pill you've got to scrape out? But I think that's definitely going to be the approach for the future.
Thank you very much. We'll have to apply the guillotine for the lack of time. And we now adjourn for coffee. Thank you very much, Professor Simon Maxwell, for the beautiful lecture.
Excuse me. Thank you very much, Professor Simon Maxwell. We request the chairpersons to honor Professor Maxwell with the certificate, please. Okay. Yes, sir. To the chairpersons, Professor Srinivas and Professor S.K. Rajan. Thank you very much, sir.
You did, once upon a time.
We'll now go for coffee and assemble in a half an hour for the next session, please.
Coffee ready, yeah?
Hello everybody, I welcome you all to the second session now. May I request Dr. Ramanujam of the Consultant Physicians, TINS VHS Chennai, and Dr. Subbulakshmi Natarajan, our research consultant, to chair the session on the confused and the forgetful elder. The speaker will be Professor Alistair McCulloch on advances in the assessment and management of delirium. Dr. Subbulakshmi, please. Professor, I request the chairpersons to conduct the proceedings.
Now I request Professor Alistair McCulloch to come on to the dais.
Speaker.
No, I think I'll be okay. Great, thanks.
Professor Alistair McCulloch is Professor of Geriatric Medicine at the University of Edinburgh and Honorary Consultant in General and Geriatric Medicine at the Royal Infirmary, Edinburgh. He is Secretary of Cerebral Aging and Mental Health, and after his general medical training, he pursued a PhD in glucocorticoids and cognitive aging. Professor McCulloch is active in geriatric medicine and acute orthogeriatrics. His main research interests are pathophysiology and neuropsychology of delirium. He leads the Regional Delirium and Dementia Implementation Group. He co-founded the European Delirium Association in 2006 and is its current president. We're happy to have Professor McCulloch here, and I request my colleague to say a few words.
I'll just introduce the topic. In about 3 or 4 minutes, I'll finish it off. And I'm thankful to Dr. ESK. I'm thankful to Dr. ESK for giving me this opportunity to chair this session. And I can see before me the galaxy of audience, starting from legendary neurologists to nursing students, the various paramedical and other groups. The previous topic was polypharmacy, where it was general topic, and now we are going down to the this phenotype of this delirium, or otherwise known as acute confusional state. And I'll just briefly mention a few points to brush up, so that the speaker's talk will be more elaborative. And the current term delirium comes from the Latin de, meaning off, and liri, meaning rails, off rails. According to Diagnostic and Statistical Manual of 4, definition of delirium is a syndrome of disturbed consciousness, attention and cognition or perception, which develops acutely, fluctuates during the course of the day, and is attributable to a physical disorder. Prevalence: recent estimates of in-hospitals mortality rate among delirious patients have ranged from 25 to 33%, a rate similar to that of patients with sepsis. The screening tests are confusion assessment method, organic brain syndrome scale, the delirium rating scale, the delirium detection score, and the ICU version of CAM. History: it is estimated that nearly 1/3 of all cases of delirium are secondary to medications, especially in the elderly. Physical exam: tangential speech, a fragmentary flow of ideas, or inability to follow complex commands often signifies an attentional problem. There are formal neuropsychological tests to assess attention. A simple bedside test of digit span forward is quick and fairly sensitive. A simple MMSE can reveal some information regarding orientation, language, and visuospatial skills. The workup consists of battery of tests which includes EEG, head imaging, and lumbar puncture. The categories of delirium are hyperactive, hypoactive, and mixed. The hyperactive is alcohol withdrawal along with prominent hallucinations, agitations, and hyperarousability, often accompanied by life-threatening autonomic instability. Second is hypoactive, which is opiate intoxication. And third is a mixed type, which swings from hyperactive to hypoactive. Some episodes of delirium may continue for weeks, months, or years. The major two risk factors are old age and baseline cognitive dysfunction. So the EEG data in persons with delirium usually shows symmetric slowing, a non-specific finding that supports diffuse cerebral dysfunction. The two chemical neurotransmitters, acetylcholine and dopamine, play a lot of part in the production of delirium as well as in the treatment of delirium. The best treatment for delirium is prevention and to place the patient in an environment that is least likely to cause confusion. It is important to structure the environment, minimize risk factors such as polypharmacy, restraints, catheter, malnutrition, and other iatrogenic complications. Lastly, coming to forgetful, that memory, which consists of the limbic system. This is with the paralimbic system such as hippocampus, amygdala, and entorhinal cortex, the anterior and medial nuclear thalamus, medial and basal parts of striatum and hypothalamus collectively constitute a distributed network known as the limbic system. An additional area of specialization for the limbic network, and the one that is most relevant to clinical practice, is that of declarative or conscious memory of recent episodes and experiences. A disturbance in this function is known as amnestic state. Implicit memory, patients with amnestic state can acquire new motor or perceptual skills even though they may have no conscious knowledge of the experiences that led to the acquisition of these skills. Retrograde amnesia involves an inability to recall experiences that occurred before the onset of amnestic state. The second and most important component of the amnestic state is the anterograde amnesia, which indicates an inability to store, retain, and recall new knowledge. Patients with amnestic states cannot remember what they ate a few minutes ago or the details of an important event they may have experienced a few hours ago. In these acute stages, there may also be a tendency to fill in memory gaps with inaccurate, fabricated, and often implausible information. This is known as confabulation. Patients with amnestic syndrome forget that they forget and tend to deny the existence of memory problem when they are questioned. So with this introduction, I request Professor Alistair McLeish to start his lecture. Thank you.
Thank you very much. Thanks for the generous introduction, for our hosts for arranging this very exciting event. It's a great pleasure to be here, my first ever visit to India and definitely not my last. We were treated to great hospitality yesterday, having a short 3-hour tour of the city, but got a flavour of the excitement and all the different things it has to offer, and also a wonderful reception last night. So thank you for this generous welcome from our hosts and for the opportunity to speak. So my talk today is focused on delirium, and I'm really going to be focusing on the clinical aspects, because although I do lots of research in delirium, I thought that I would just focus on this. And I want to preface my remarks by just saying that delirium, although it's very common, affecting more than 10% of hospital inpatients, it's not a condition that's that well researched. So some of the things I'm going to be saying today are evidence-based, but many are not. Many are based on expert consensus or common sense or, frankly, my opinion. So I'd actually be very interested, and maybe there will be time for discussion after to hear comments and feedback, because I learn a lot from comments and feedback in talks, and I often, when I learn something, you put it into the next talk. Okay. So just in case everybody here is not totally familiar with it, I thought I'd just go through some of the basic features. So delirium is a severe, acute neuropsychiatric syndrome which at its heart is a syndrome of cognitive impairment. So people with delirium always have cognitive impairment, and the main cognitive feature that's disrupted in delirium is attention, and I'm going to talk in some depth as to what that means later on. But it's not just cognitive, because many patients with delirium also have reduced or increased level of consciousness, so they can be drowsy or agitated. And they also have psychotic features in around 30 to 40% of cases, hallucinations which are typically visual or delusions. Delirium is classically a transient disorder, so in about 80% of cases it will resolve within a few days. 2 to 3 days is the most common duration of delirium. But it's very important to think about those 20% of patients in whom delirium doesn't resolve quickly. And in fact, some patients get delirium that lasts for weeks or months or even longer, and it emerges into a kind of dementia-like state. So it's not the fully reversible condition that people used to describe it as, and it's certainly not the benign condition that people used to describe it as. And it mainly affects older people who are hospitalised, although it does affect children as well, and any sick person can get delirium. And in intensive care units in our country, around 50% of people have delirium at any one point. So it's a massive healthcare problem, but it mainly affects older people. And unfortunately, the old medical textbook ideas about delirium are often wrong when they say that delirium is a transient and benign condition which doesn't have too many implications. Because in fact, it's very common, as you can see up there, more than 120 patients on average in a 1,000-bedded hospital like mine, 20% mortality a month, 3 to 5-fold risk of new institutionalization, which is a massive statistic when you think that a patient living at home comes into hospital with delirium and they've got a very high risk of never going home again in my country. And in Edinburgh, for example, 70% of people who are in care homes have come from acute hospitals. So they were at home before, they come to hospital and they never go home again, they go to a care home. So the statistics are really kind of frightening, especially when cognitive impairment is by far the most common reason for somebody never to go home again. Something like 70% of people in care homes have dementia or cognitive impairment. Delirium is also very distressing, and in my opinion that's the only reason you need to care about delirium, is that it's distressing for patients. I mean, we don't need to be given lots of justification to think about pain, do we? Pain is an end in itself. You want to care for people who are sore to make their pain go away, and it's the same with delirium. Because delirium is distressing, detecting it and caring for it well, simply because it's distressing, is all the reason that you need to do it. There are many other reasons, of course, but I think that is often the pivot that I use to make an argument for actually making delirium care good. Needless to say, delirium is also very expensive, and I'll give you a statistic on that in the next slide. But despite all of this, it remains very under-researched, and its pathophysiology is unclear. We don't have pathways that we can target with drugs yet, that we don't understand that. We don't understand why people with delirium get dementia after delirium, which is now pretty much a fact in the evidence, and so on and so on. And there are no treatments for delirium that are licensed in the world. It's kind of stark for a condition that affects 120 people in a 1,000-bedded hospital. No treatments. So, extrapolating a little bit from what I said in the last slide, why care about it? And the reason that you have to have a slide like this is that in the UK, only 20% of delirium is formally detected. And that's actually the case throughout the world. You know, in any study where you look for what are the rates of delirium detection, no matter which country, America, European countries. Holland's a little bit better because they've embedded delirium detection in many of their nursing protocols. So that's actually better than most countries. So people don't care about delirium that much, or they don't understand it, or they don't know that it's so important. So in some recent research on the education of delirium, just simply bringing the hearts and minds argument to the table was the most important one, just to say this is why you should care about it. But apart from the distress argument, it's also important to realise that delirium often indicates life-threatening illness. I mean, I've already said that 1 in 5 patients with delirium are dead in a month. But one of the things that brought it home to me as a registrar was when I was asked to see a patient who was confused and not coping at home. This was a patient in the emergency department who'd been seen by the acute medical team very briefly, as is usually the case, and just passed straight to medicine of the elderly team for further evaluation. So I went to see this patient who was obviously drowsy just from the end of the bed. Eyes were shut, didn't open his eyes when I came to speak to him, only opened his eyes a little bit. And so already the diagnosis of delirium is made just from that 3-second observation, because any acute drowsiness is delirium, effectively. But then I looked at his observations chart, because that's what you have to do next, and his systolic blood pressure was 92, his oxygen saturations were in the low 90s, and so on and so on. And the man had pneumonia with sepsis, and that was resulting in delirium. That was the reason for him coming in. So this was an example which we often see, is that the brain going wrong and exhibiting delirium is actually just a sign of severe acute illness. It's organ failure, really. But instead of measuring it with urea and creatinine, you measure it by your eyes and by doing some bedside assessments maybe. But in some patients you don't even need to do that. You just look at them. Another very important implication of delirium is its effect on rehabilitation. If you think, for example, that around 20%, if not more, of stroke patients get delirium, and rehabilitation is at the heart of a lot of what we do in geriatric medicine. But this must be one of the reasons why so many people with delirium never make it home, is they can't undergo rehabilitation easily. They can't understand the instructions of the physiotherapist. Their energy levels are low, they're hypoactive, or they're agitated. They can't comprehend what's going on around them. And after a few weeks of that, often your chance is gone, to get somebody back on their feet and in good shape and going home again. So it has a huge effect on rehabilitation. Often it's not recognised, and in my experience, a lot of therapists, as well as doctors, of course, don't make this a technical diagnosis. They just say the patient's unable to do rehabilitation today. They're too tired, or their confusion's too severe. I can't communicate with them. We'll come back tomorrow, we'll come back next week, and we'll try again. Instead of saying, I would certainly, my approach would be to be very curious about that. Why is this person who was going to the shops, living their life, doing the housework, looking after the grandchildren, why are they unable even to comply with a simple instruction from a physiotherapist to walk down the corridor with a Zimmer frame? Why can't they do that? That's a very severe change in that person's status, especially if the urinary tract infection has already been managed. Another very important thing about delirium and getting the diagnosis and the labelling correct is that it's not the same as dementia. So the word confusion is very unhelpful. The word confusion is fine as a presenting complaint, a bit like breathlessness. But that's where the lay description stops and where the professional description starts. And that means you then need to differentiate between chronic and acute, because the treatment's different of dementia and delirium. Different things you need to do. So just stopping at confusion is essentially useless for the patient. So as professionals, we need to move beyond the lay description of confusion. Anyone can tell that somebody's confused, but it's what does that mean? What is it? What's the technical diagnosis? The length of stay is also doubled. I mentioned about institutionalisation, but from an economic perspective, and especially with an ageing population globally, doubling length of stay in 15% of your hospital patients is a big deal. If a bed day in the UK costs £400, you're talking about delirium costing a lot of money. And as I'll show you later, delirium predisposes to dementia. So even people without baseline dementia who have delirium, they're much more likely to have dementia in the future. So it's a marker of risk and may even be a cause of dementia, but we'll come to that later. So now go on with the more clinical aspects. So the core diagnostic features that you must have to call it delirium are that it's of acute onset. Now, it's not necessarily essential to have fluctuating course, but it's present in about 80% of patients with delirium, and it's not present in other conditions. The only conditions where you might get a little bit of fluctuation, some severe dementia and dementia with Lewy bodies, but in general, delirium is really the only major mental health disorder which fluctuates to the extent that it does, so that somebody can manage to talk to you in a coherent way at 10 o'clock in the morning, 3 o'clock you come back and they're half asleep or they're very agitated and not themselves. That's really almost diagnostic of delirium, that level of fluctuation. That's what psychiatrists tell me, that they use that as a shortcut to diagnosis. Is the patient changing during the day? They ask the nurse. The nurse says yes, it's delirium. End of story. And the other cognitive feature that you must elicit to call it delirium is inattention. This might change, though, I think. This rigid DSM-4 based idea, because altered alertness or drowsiness or agitation is also pretty much diagnostic of delirium if it's acute. And this is an important thing because many people can't undergo cognitive testing if they're drowsy. And this is one of the flaws with the confusion assessment method, which you may have heard of from Harvard, that it starts with inattention, but drowsiness comes in the second part of it. So many people who are not expert in delirium just can't do the confusion assessment method because the patient cannot undergo any testing for attention. But if you can't undergo testing for attention because you're too unwell, then it's diagnostic of delirium, in my opinion, unless it's a coma. And that is something that there's beginning to be some evidence on. And there are other features which are variable, such as memory impairment. Now, not all patients with delirium have memory impairment, which is fascinating. So even people with deep delirium that you can hardly talk to them at the time, they will sometimes remember those conversations and repeat them back to you, and that's happened to me many times. And that's important because people are also very often experiencing hallucinations and delusions at the time. So it's really important to remember that memory may not be impaired. If somebody has dementia as well as delirium, often the memory is very impaired, but it's not inevitable. Psychotic features are pretty common. I've mentioned those already. Hallucinations and delusions. Hallucinations can be they're very rarely pleasant. They can be neutral, but they're mostly unpleasant. For example, one lady that I was seeing a couple of weeks ago told me that in her room of 4 beds, on the 3 other beds where there were no patients at their bedsides, there were dolls sitting on every square inch of the top of the beds, all looking at her. And round the room there were dolls pinned to the wall, again all looking at her. And there were children with white skin and long black hair and white dresses playing, but sometimes they would all look up at her like this in a sinister way. And this went on for several days. And patients very rarely admit to these things because they think they're going mad, they're embarrassed about them, and so you often have to ask about them. But it's very, very common for people to have these experiences in hospital. A large percentage of our hospital patients are experiencing this right now, and it's not being dealt with. Sleep-wake cycle disturbance is really common in delirium, and it's not that useful as a diagnostic feature, but it's important to note it in case to see if you can manage it. But I'd like now to talk a little bit about the terminology, because this is I think the most important step forward in delirium management is just to get the labelling right. Now, you will have seen many of these kinds of labels being used in hospital. I mean, this is, whoops. So this is my favourite one, subacute befuddlement. Honestly, that was somebody's serious suggestion for what we should call delirium. And I'm really glad it didn't catch on, because I wouldn't like that conversation with a relative. I've got the answer. It's subacute befuddlement. So luckily it's not that, it's delirium. This is the old term, which went out in 1994. That's quite a good term, acute confusional state. It does what it says on the tin. A well-known advert in the UK, that's what for paint remover or something, that's what they call it. It does what it says on the tin. But the trouble is it gets shortened to confusion, and then it gets mixed up with dementia. And also it's not in an official diagnostic coding system now. So I think that phrase, acute confusional state, should not be used. If you have got as far as saying this patient has acute confusional state, just don't use it. Instead, use the term delirium. It's as simple as that, because it means exactly the same thing. It's just that it's an outdated term. And all these other terms. And these are just the kinds of descriptions of patients which often indicate delirium. A bit knocked off. Not themselves. If you don't want a word round, the nurse says that patient's not themselves today. That, to me, is probably 90% likely to have delirium. Unless they're sad about something because somebody's told them some news or something, but often that's what it means. So, my very strongly held opinion is that imprecision is a major drawback and a major threat to patients with delirium. Because of this, because when you say that somebody has delirium, it's an acute disorder and it stimulates acute action. Confusion doesn't do that, does it? It doesn't mean this doesn't have the same weight as a trigger. Delirium does. I certainly feel a sense of urgency When somebody writes, this patient has delirium, when it's written in the notes, I feel that that's an urgent thing that needs to be managed urgently. If they say dementia or confusion, it doesn't have the same, power behind it. So let's just all agree to use the word delirium and put the past behind us. Get rid of all those old terms and just move forward in a coherent manner. So my approach is to start with the level of alertness, then go to cognition, and then look for evidence of onset. And I start with alertness, and this is against what some of the older textbooks and review articles will say, because the reality is that it's very common to see drowsy patients in hospital, isn't it? Would you say that that's true? Lots of patients are a bit sleepy. In one study in Fife, 4% of all acute admissions over the age of 65 were too drowsy to undergo cognitive testing. And by the time you get people into hospital, the proportion goes up. I haven't studied this, and I probably should study it. How common is it actually? But it's certainly 4 to 5%. 1 in 20 old patients in hospital are drowsy. Probably more than that. Certainly after surgery, because I cover orthogeriatrics, it's much higher than that, 20%. And some of these patients are too drowsy to undergo any form of testing or interview. You can't have that meaningful conversation with them. And I start by simply saying, can you tell me, I'd introduce myself, and if they open their eyes at all and are at all aware of me being there, which often isn't the case, I will say, can you tell me your full name and address? And that's a good way of starting to the test of whether they can actually speak, whether they can hear you and whether they can speak. Obviously you're looking for hearing impairment as well, but if they can hear you, but many of these patients are labelled as untestable. So sometimes in our urinary patient record, which is the document that all medical admissions get, there's the abbreviated mental test, the 10-item mental test, and often there's just a line through it, and it just says, could not do, or too drowsy, or too unwell. That's actually a score of 0. It's not undoable. A score of 0 on an AMT, very serious thing to have. You're too sick to do an AMT. That means something, doesn't it? To me, again, that is, in many cases, going to be delirium. So I think we should basically, if somebody's too sick to undergo testing or interview, and it's acute, they're too drowsy, just call it delirium. The treatment's exactly the same. And I actually asked this of Sharon Inouye, who's professor of medicine at Harvard, who is, I think, regarded as the queen of delirium in the world. Asked her this at a conference, because some people advocate that you need to demonstrate inattention using a cognitive test to call it delirium. And I was saying, surely the safest approach is to call all acutely altered mental status under this umbrella term delirium, because the treatment is exactly the same. Do you not think the treatment's the same? And she said, I don't agree with the idea that you could call it delirium, but I do agree that the treatment is exactly the same. So I was going, Anyway, we need to do some science to back this up. But that's the safest approach, isn't it? I mean, certainly the initial workup's the same. So how do you assess alertness? Well, I've mentioned just asking them to tell me their name, and I think the AFPU scale, is that a scale that's used in India? It's used across the UK a lot and in other countries. Just basically a 4-point rating scale of how alert somebody is. Are they alert? Do they respond to voice, pain, or are they unresponsive? Glasgow Coma scale, which I think is universally known. And I quite like to write down how much they're opening their eyes, are they having eye contact, how much movement are they showing, what's their posture. Because I think somebody lying at 30 degrees with one leg over the side of their bed, everything in a bit of a mess in their bed, that patient's unwell. Often people who are a bit better and have got more strength to sit up, they're sitting straight, they've tidied up a little bit. So all those things can give you a lot of clues that something is up. Now what about testing cognition at the bedside? So if they're well enough to undergo cognition, I really like using simple bedside tests. This is a pretty good test, which is in the AMT. These are 2 commonly used bedside tests in delirium. We haven't really cracked this problem though, to be honest, because I've certainly seen patients with delirium who can do 20 down to 1, especially people with a high baseline cognitive ability, a retired professor of maths, bang, 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 down it goes, and and then they go back to sleep again, and this is also a pretty easy test, days of the week backwards. And often I've seen patients with definite delirium who can do that test. So I don't like to advocate it as a screening test for delirium. I think this is a pretty good screening test for delirium, but it also picks up dementia, because months of the year backwards is quite hard. And so we actually have not cracked this problem of what is a test that has an adequate balance. So I sometimes just do two of them. I do this and this, or this and this. And I write it in the notes, because it's very useful to have that information. Because if you use, essentially language is just are quantifiers, binary quantifiers, aren't they? So if you just say somebody's drowsy or not drowsy, or confused or not confused, it's a simple 0 or 1 classification system. And this adds a bit more grain, to the assessment, doesn't it? It's useful to know that a patient could not do 20 down to 1, or they could do the 20 down to 1, they got as far as 15 then stopped. And you've got that in the notes. That's more useful to your colleague coming on the next day, or somebody coming in a week's time and they say they can bang them all the way down to 1, no problem. You say, well, they've improved, rather than saying they were a bit vague today. So I really advocate the use of these tests. The more standard tests like AMT, MMSE, MOCA, ASR, they're pretty sensitive to delirium, but they're not specific, so they're kind of less use. But they can be useful in tracking change. They have their dangers too, though, those tests in delirious patients. Because, I don't know if you use the MMSE routinely. So somebody who doesn't understand delirium, this is why it's so important to get the labelling right. You know what it's like? Somebody can do the MMSE, a medical student maybe, or a junior doctor, write 15 out of 30 in the notes without a context around it. Later on, someone is writing the discharge letter and they say MMSE 15 out of 30 without saying due to delirium, and the retest was 26 out of 30. And that patient is then labelled, sometimes with the word dementia, as an accident because of simply imprecise diagnosis. And that can have massive implications for that patient. Because, again, I don't know what it's like. Obviously there's a variety of different types of hospitals, but certainly if an ICU physician, you make a referral to an intensive care unit physician because somebody might need intensive care, and they look through the notes and they say, oh, I see back in 2009 they had an MMSE of 15 out of 30. Clearly they've got dementia. I don't think we should offer them a space in ICU because they won't get benefit from it. That definitely happens. So the MMSE has got a potential really bad side to it in delirium, in the sense that it just becomes this number that everyone believes and puts a lot of faith into. But actually, you could be interpreting it wrongly. So use these tests with care. Now, acute onset is usually not that hard to pick up as long as you make the effort to pick it up. That's all I would really say about it. You might know the patient and see that they've changed. And that's the easiest of all, isn't it? You just say, that patient was fine yesterday, they're not fine today. Delirium it is. Sometimes the patients know themselves. But usually in retrospect, they say, oh, I wasn't myself 2 days ago, now I'm much better. So it just needs to be remembered. Now, I just want to mention this quickly. If you want to make your name in medicine, then come up with a test with a good acronym. And this really, in recent medical history, this really takes the biscuit for an absolutely fabulous acronym, SQUID. And this is it. This is the test. That question is the test. And they studied it in 19 patients in palliative care setting, 5 of whom had delirium. And it worked pretty well, just a simple test. It missed one, which is a bit of a shame, and obviously it over-included some, but that just simply shows that, and this is almost, I think, a slightly satirical paper, just to sort of show you that if you just ask this one question, it's nearly as good as a half-an-hour interview by a psychiatrist. So, and it's so cheap and simple to do, we should just do it. And so anyway, well done to the canny Australian authors of the SQUID for their great acronym and pointing out the obvious, but providing some evidence for it. So we have written a new test in the Royal Infirmary, and I wrote it with a couple of psychiatrists. And the reason I wrote this is because the confusion assessment method takes too long. You need to do a cognitive screening first. It requires the doctor or nurse or other professional to make a judgment about whether somebody has attention or inattention, whether they've got disorganized thinking, a subjective judgment. Now, subjective judgments are aversive. People don't like to make them, especially if they don't feel on top of their game. So, most doctors, they'll tell you what the urea and the creatinine is happily and what it means. But if you say to them, has that patient got disorganized thinking? Tell me in your opinion. Does they have, what does that mean? How do you judge that? It's a verbal exchange. It's difficult. So, and lots of studies have shown that the confusion assessment method cannot be implemented successfully in routine care because the training costs are too high, it takes too long, and eventually people drift away because they don't like, on a daily basis, to being forced to nail the colours to the mast and say this patient has inattention or disorganised thinking on the basis of a short subjective interview. It just doesn't work. So, we thought we would try and overcome these problems to try and improve the delirium detection rates in our hospital. So the 4 A's test. So 4 A's are alertness, AMT4 attention. I'm not going to go through it in detail now. It's on one page with a bit of instructions at the bottom. And I wrote a website, and it's public domain, and you're very welcome to have a look and let me know. But it's being used in several UK hospitals in Australia and the States. We've done it back to front in that we developed it and tested it with 20 junior doctors informally in clinical settings and just started using it because it works quite well. That's our impression. We need to do the studies now to back it up, but we couldn't waste 5 years doing the studies, and we just thought we're just going to do it because it's basically just collapsing what we do in clinical practice anyway. But I'd be really delighted to get some harsh criticism of this, and some, if we've missed something important or you think we could do it better, let me know. So just a few words now about pathophysiology. So this comes from Sharon Inouye. It's one of the most important studies in delirium, and it proved what people sort of knew but hadn't really been looked into properly, that if you have lots of comorbidities, especially dementia, you need a much less noxious insult, like a mild urinary tract infection, to create delirium, and vice versa. And that's pretty much true. It may be that we develop more finer grained ways of looking at it, because I've certainly seen many patients with lots of comorbidities who are ill who don't get delirium. So there might be some brain specific or genetic factors, but essentially this is true. What about trying to understand the pathophysiology of delirium? And classically in medicine we look for molecular pathways, don't we? We say there's this gene that goes wrong, it produces the wrong kind of protein, and that feeds through to this, or you take this drug, activates these receptors, it causes that. And it's kind of often boiled down to single pathways or single chains of events physiologically, like heart failure, for example. That's the account that's normally given. We don't have that for delirium, unfortunately. It's just it doesn't. The pathways to disrupted brain functioning are not well understood. As one American neurologist said to me, there are many ways to trash the brain, was his way of putting it. Quite interesting, but it's kind of true as well. And so some wit said that actually the whole of medicine causes delirium, there's no point in studying it. Just give it up. In fact, one of my research fellows didn't get her fellowship from a particular grant-giving body because they said delirium could not be studied because it's too complex and too difficult. Luckily, she got funded by somebody else with a bit more sense. Anyway, so I divide the causes in terms of research and also in clinical practice into two broad categories. The first being direct interference of brain functioning, and this is not rocket science. If you deprive the brain of its fuels, if you poison it, or if it gets damaged by a stroke or a direct head injury, it's not surprising that complex cognition, which is the thing that the brain does, it requires the most expense and the most bits of the brain, it's no surprise that that can lead to a disrupted cognitive state, which we then label delirium. And I don't think there's that much to be studied there other than trying to avoid those things. But then there's this other thing. And this comes from a forum, a UK forum of geriatric medicine, and this was a registrar saying that she'd been asked this question by a relative, and this registrar had tried to start answering by talking about cerebral reserve, and the brain doesn't work too well, but she realised she had no idea. How is it? And I think it's one of the fascinating, big unanswered questions in the whole of medicine, affecting lots of people in our hospitals every single day. How is it that a patient with a UTI who's got normal blood pressure, no pyrexia, no raised white cell count, we all see these patients every week, How is it that that UTI makes them as psychotic as somebody with acute schizophrenia in one day? What's that? And to me, that's one of the most interesting and strange questions in medicine, and one that we see on it, but there's hardly any research on it. So we don't really know the answer to that question. This is another way of putting it. How does that happen? And there's some evidence that there are various pathways which can signal to the brain that there's inflammation in the periphery, and that in vulnerable brains there might be an exaggerated response, too much dopamine, too much suppression of acetylcholine and so on, but we don't really know the answer to that. But certainly I think that it's not just about direct damage or insults to the brain, it's about other pathways, stress, inflammation, and cortisol is something I study a lot, and we know that in old people you get a big surge of cortisol in most old people after, but the key thing is it lasts for much longer, and that might be one of the reasons why they get delirium much more. But I'm not going to go into this because this is a different talk really, but just to mention that there's direct brain insults and aberrant stress responses, and we did a review article on this in 2008, which I can send you the reference for if you're interested, as the two main pathways to delirium. And this is important because dealing with this therapeutically may be another way of attacking the treatment of delirium. People sometimes talk about a final common pathway in delirium, and I simply don't agree with that. I think there's multiple routes. I think there are some pathways that are common, like cholinergic deficiency, dopamine excess and so on, but in many patients there's a mixture of things going on. Now on to the management. So the first thing, once delirium is suspected, is to check for acute life-threatening illness. And this is something that's missing from a lot of pathways. And I frequently see patients who present with delirium who've got very bad opioid toxicity, which is life-threatening because they could aspirate and die very easily. Aspiration pneumonia has got a very high mortality rate in old people. Low blood pressure, low BM, and so on and so on. So basically just basic general medical approach to the sick patient that everyone is taught, but it needs to be switched on when delirium is suspected. Once that's been done, I think there are two main prongs to the attack on delirium. Treat clear precipitating causes, and then optimize brain functioning. So, treat the causes. Now, this is different from treat the cause, which is what is in most textbooks. It's because usually there isn't just one cause. Usually there's more than one cause, and that's one of the raison d'etre of geriatric medicine, is that we think multidimensionally instead of in terms of single pathways. And that is the case in our specialty, that patients rarely have a single pathway. I mean, if they've got gout, fair enough, it's got a pathway, you can fix it, although there might be a diuretic that's made that happen. But mostly it's, and in fact the research has shown that a minority of a single case, many cases you can't even find an acute cause. So multiple possible pathways, so treat the causes. The detailed assessment to get those causes, now people often say do a full history and examination. That's kind of true, but it's difficult to do that, with the pace of acute medicine. So you have to look for acute illness, including neurological illness. Drug history is essential, screening bloods, and over the days that they're in hospital you try and piece together a comprehensive geriatric assessment, but you can't do that at the front door in 20 minutes. So you have to look for the acute things first. And these further investigations come down the line. CT is indicated early in delirium if somebody's on warfarins in case they've got a hemorrhage, if they've got focal neurology, if they've had an obvious head injury, or there's focal neurological deficits on examination that are thought to be new. Apart from that, CT is not indicated initially. The evidence shows that you should only really do it, I would say, 4 or 5 days after they come in, when you've tried other things that hasn't worked, and then you might find a subdural or a brain tumour that hasn't yielded a focal neurological sign. LP is very rarely used in general delirium management. I mean, if somebody's got neck stiffness, you'd expect a general physician to pick that up at the door, front door, drowsiness plus neck stiffness. But if that emerges as a possibility, a CNS infection, maybe you can do an LP. But to be honest, it's not really that useful, and it's quite a traumatic thing to do, so we don't do that many of them. We only really do EEGs with persistent puzzling delirium to look for non-convulsive status epilepticus, but that, I think people occasionally say in talks that they've seen one, but it's not something that comes up very much, to be honest. These are some of the common causes, which I'm sure everybody here is aware of. I just thought I'd put them up for the sake of it. Stroke, I think, is underrated or underestimated as a cause. I think you can get cognitive strokes. I think you can get strokes which are not necessarily causing motor problems, but which are purely causing an attentional deficit. That's what I recognise actually with case reports, but it's not organised into a normal content that you'd have. The trouble is CT won't pick these things up very easily, but sometimes we do see that somebody who's got a very puzzling, persistent delirium, we think, what on earth is wrong with this patient? You do a CT scan and they've got a frontal lobe infarct. And you could think, well, it looks a bit fresh, it wasn't on the last CT scan, maybe that's the cause. So, but I think MRI in the patients, if you've got common causes of this is I've seen this many times, chronic limb ischemia. But this gets into the Oxford textbook of medicine, the whole of medicine then you're into, so that's really a matter for a senior experienced doctor to spend 40 minutes, an hour going through the case and checking everything really in fine detail. What have we missed? What do we need to do? Sometimes that yields the angle that then gets the patient better. She was calling out in non-verbal sounds frequently, howling, very distressing. People kept giving her haloperidol. She's agitated. She's agitated. And I came to see her in orthopaedic ward round, and I was thinking something funny about this. With the howling, she's very distressed. Maybe she's in pain, but she can't articulate it. She couldn't talk. So we went through her, top to toe, and. When you fixed it, we went back to her MSc therapy 3 or 4 days later. So pain really needs attention. You need to look for it. So another part of optimizing brain is to review the drugs, and Simon Maxwell did a great job of highlighting the importance of having proper rationale for all the drugs that you're using in these patients. Many of these drugs, certainly antihistamines, are usually not required for long courses. I mean, I don't often see patients who need antihistamines forever. Quite often they come into hospital on them and just think, well, we'll just stop that and see what happens. Quite often nothing happens, and sometimes they get better. People often need prednisolone, and sometimes you need to increase it in hospitals. So this list is not to say stop those drugs, just to look at the necessity. And often in hospital you're thinking, blood pressure's 116. Do they really need that amlodipine, when they're falling? I would just get rid of the amlodipine, and if the blood pressure goes up to 180, you can start it again. But, let's just let the blood pressure ease up. There's some systematic reviews say that amlodipine is associated with double the risk of delirium. I don't know why that is, but it's coming out in the evidence. Opioids, again, you have to balance the use, treating the pain effectively. Benzodiazepines are really bad drugs. They're seductive to the patients, the doctors, and the nurses, because everyone feels good in the short term when a benzodiazepine prescription happens, but they're lethal drugs because they cause delirium, or they make delirium worse, they make it last for longer, they make patients fall, they do all sorts of terrible things to patients, and we shouldn't really use them unless you really know. Used in India at all, lidocaine.